We are live.
A very good evening. Welcome to day 12 of iFocus. I once again welcome Dr. Thomas Kuriakose. He is a professor at Christian Medical College, Vellore. And I'm sure after the last lecture, all of you must be very eager to get on with this one. They say eye is the mirror of the soul. And today's class will be on the importance of systemic examination in ophthalmology, another very important but not so often discussed topic. So over to you, sir.
Thank you, Ritika. Thank you, Mritika. I'll just share my screen. Is that clear now? Can you see it?
Yes, sir.
Okay. So as was mentioned, my talk is on systemic examination in ophthalmology. Again, start with disclosures. This is not to pass the exams, okay? This is to enjoy being an ophthalmology physician. And we will concentrate on the principles and not give too much details because I want to keep this lecture well below 45 minutes so that in case you have any issues, I can answer that. Now, to me, the beauty of being an ophthalmologist is that we are physicians who can operate. And when we operate, we deal with the most delicate parts of the body. I don't think there's any other surgeon who deals with structures which are 1/10 the thickness of our hair, which is the posterior capsule. Now, it has been mentioned that the eye is a mirror, but more importantly, it's also a window to the body. Because the eye does the function of the eye is to let the light in up to the photoreceptors. All the structures in front of it is transparent. Because of that, it offers us an opportunity to see both the arteries, the nerves, and even part of the brain, which is the optic nerve, directly. So we really can see all these structures in vivo. And the eye is made of all the embryonic layers except the endoderm. And because the layers are transparent, actually we can see into these layers. So any changes in these layers, we can make out. So the eye is a window, and it's also a mirror. In what sense? The eye will mirror the systemic diseases patients have, okay? And because of that, examination of the eye is important, both to figure out the systemic this thing, and we also should, as ophthalmologists, should learn how to do a basic systemic examination. And I will tell you why we have to do that. Now, some of you must be thinking, examine other parts of the body. You must be joking. In this era of subspecialization, when the cornea guy cannot even examine the retina, what are you talking about examining the other parts of the eye? Well, to me, the people who can just examine only their bit of the eye, to me, is a technician. And the difference between a technician and a doctor is the doctor sees the patient as a whole, whereas the technician sees only the area needed, nothing else. The doctor makes a diagnosis, whereas for the technician, the diagnosis is already made. You know, the patient has got cataract, the patient has got myopia, and then from then once, so patient, the diagnosis is known, all you need to do is follow the protocol. So what do you do for myopia? Just do that, or you put them onto the laser and just the machine will do that. You may or may not, the doctor may or may not decide to interview, whereas the technician has to interview. You know, it has to be a procedure has to be done. You send the patient to the fields, that fellow, doesn't matter what the diagnosis is, they will do the field test. Okay, you send him for an OCT, that will be done. So that is, they need not worry about the, whether it needs to, or they have no independent decision-making capacity. So that is the main difference. And I hope all of you want to be doctors, and to be a doctor, you really need to also be good at systemic examination. why systemic examination? Now, an ophthalmologist, to make, there's one more thing I want to tell you. It is said that, you can make out most of the diseases, systemic diseases have an ophthalmology manifestation sometime or the other. Even your COVID right now has an ophthalmic manifestation. So, so you can to make ophthalmic diagnosis, you will sometimes have to do a systemic examination. The patient comes to you with just hemorrhage in the eye. And then the hemorrhages could be due to so many things. And then you may suddenly see that this patient looks very pale and there may be a few nodes. And then you think, yeah, okay, this patient may be having a leukemia. So, we as ophthalmologists don't need to do any. So the ophthalmic diagnosis is due to a systemic cause. Sometimes you can make a systemic diagnosis based on the ophthalmic findings. And so here again, so that's the opposite is that, let's say you see subluxation, and then you want to know whether this is due to Marfan's or is it due to Weil-Marchesani's or any other problem. So for that, you need to again do a systemic examination to rule out or rule in a particular disease. When you want to do cataract surgery, again, you will probably need to know whether his cardiovascular system is all right, whether his lungs are all right. So that is again important for you to do a systemic examination. To make a sensible referral. So let's say a patient comes to you with uveitis, and then it may be due to leprosy, in which case you will send it to a dermatologist, or it may be due to rheumatoid arthritis, in which case you will send it to a rheumatologist. So, to make a sensible decision as to whom to refer, you will really need to then do a systemic examination to figure out what is the problem. Some of you may be having these doctor stickers in your car, and you may be in an emergency situation asked to, call for help. Of course, at least you should be able to do is, see if the patient is alive or dead, and then some first aid if possible if the patient is alive. To me, the best part of systemic examination is I can be the true detective to figure out what the real diagnosis is, and that's what I enjoy the most. Now, when you're doing systemic examination, I would suggest that you have somebody in the room with you. Have a chaperone, especially for the male ophthalmologist. If you're examining female patients, you should have a chaperone. As it is, patients may not expect a systemic examination when they come to the ophthalmologist. And so you should have a chaperone and also take a permission so that they are aware that, you need to do these tests to figure out what the diagnosis is or to give further opinion. And the chaperone is also required for your medical legal protection. Now, systemic examination starts as the patient enters the room. His gait may give you a idea as to what a broad-based gait, may give you an idea what the diagnosis may be. Facial expression, a mask-like face may say, okay, this may be Parkinsonism, which may be causing his dry eye. Posture. Can any of you on the bench tell me what do you think this patient here has on the right side? Can you take a guess? Anybody? Sorry?
Parkinson's?
No, not Parkinson's. Ankylosing spondylitis. Okay, this is a typical of an ankylosing spondylitis patient. His neck is stiff, he's sort of bent forward. So ankylosing spondylitis. So as you walk in, you bend, sort of make the diagnosis. And imagine, even if before he talks to you or tells you that he's ankylosing spondylitis, if you ask him straight away, do you have the ankylosing spondylitis? He'll be taken aback and he'll think you're a wizard. Okay. Whole body inspection. It's always good to have a look at the patient from head to toe. And, sometimes this sort of features, thrusted out thorax, this sort of faces. Any idea what this may be? Any guesses? This is mucopolysaccharidosis. Okay. This is the faces you see in mucopolysaccharidosis. Sometimes you can look at the trunk to look for caffeole spots. So a whole body inspection is also useful. Just look at the patient. Now, as an ophthalmologist, you have access to the face and you get a lot of information by looking at the face. Dysmorphic features. This child on the right side, it's not classical, and I purposely did not want to put classical pictures. That is easy to pick up, but these subtle signs like these, prominent central bulge is seen in craniostenosis. Okay, so you need to look for dysmorphic features like this. Acromegalic face. If any of you have seen the Goldfinger, the James Bond movie, the typical thick jaw, acromegalic faces, as the patient walks in, you should be able to guess. A saddle nose you may see in Hansen's patient or a patient with syphilis. Again, examination of the face, you may see adenomas like this on the face, which is again suggestive of tuberous sclerosis. So you should, if you see some hematomos on the retina, you should probably know what that is. Facial swelling, sometimes patients come with, may not tell you, and the eye may be all puffed up, and or one side of the face may be swollen, which may be very subtle. You may have to pick up that asymmetry, especially sinus diseases. When there is sinusitis that side, there if you look for it, you may find a swelling. Mask-like faces, like I mentioned previously, extrapyramidal symptoms, you can get it. Facial deviations. This patient is one with facial deviation, and you have a left-sided sixth nerve palsy. Now, the patient may just come to you with just presbyopic symptoms. Okay, it's your job to pick up these xanthelasma spots and then ask the patient whether they have hyperlipidemia. If they tell it, if they do have hyperlipidemia, they'll be quite shocked. Again, you'll impress them. How did you figure that out, sort of thing. But if he doesn't know, you'll have to refer them, for that. Sometimes patient will come just with red eye, and unless you look carefully in the face for an umbilicated lesion, which is suggestive of molluscum, you may totally miss the cause of the red eye. This is an obvious case of herpes lesion, herpetic lesions on this side of the face, but quite often these lesions are not very obvious. They may just be a maculopapular rash, and a patient may just come with headache and eye pain, and you may think it's angle closure glaucoma or uveitis or something like that, and you will miss the herpetic lesion, and then when it really crops up, you will be in a bad light. Part of the examination of faces, you should look for the eyebrows. See if there is missing lashes, hair in the lateral part. You should think of Hansen's or leprosy disease, or even myxedema, the hypothyroid state. You can get that. Look at the ear, extra nodules like this, golden hare. You can see a limbal dermoid. So don't forget to look at the face properly. Now, facial rash. Now that's important to look at. What do you think? Can anybody tell me what is this rash suggest? What is it?
Butterfly rash.
Yeah, where do you see that?
The stomach.
Yeah, very good. Okay, so what do you think has this child got? What do you know what this lesion is about? Okay, vitiligo. Yeah, I mean, it is possible. But what I want to impress upon you is this child, this patient. Again, if you look for it, there's this thing, and all three have SLE. Okay, so we may read Western textbooks and then think of in our heads or see the atlas of Western patients, and then we may miss totally the rash that presents in other pigmented race. So so don't always have that stereotypic view in your head. So some patients may present like this, also SLE. This sometimes even looks like almost like a makeup, but this is again an SLE rash. So what I really want to impress upon is pigmentation can change your findings. So be aware of that. In patients with unilateral glaucoma, nasolacrimal duct block, and things like that, patient may deny a trauma, but then when you look at the face, you will see that this patient has had a trauma in the past. And why would not they tell you about the trauma? Because, social stigma, it must have been a spouse who has hit her or something like that. She does not want to reveal it, those sort of issues. So it's up to you to sort of pick up that finding without really embarrassing them. Examination of the mouth. This is something, sometimes people miss out. Patients who may come with just punctate opacities in the cornea, maybe well-to-do patient, but sometimes they may be having malabsorption syndrome. It's not always that the deficiency occurs in malnourished now. They may be having an intestinal malabsorption syndrome. Okay, so it's up to you to look at the mouth, look for angulostomatitis or this magenta colored tongue, glossitis patches, again, all suggestive of vitamin B deficiencies, which you should pick up. You may have tremors in the tongue, which may be motor neuron disease. Deviation of the tongue, again, suggests you have a 12th nerve palsy. Then you have to ask the patient to open mouth, look for necrosis, necrotic patches in the eye, especially if you're suspecting giant cell arteritis. Okay, so look at the mouth, giant cell arteritis, you may find necrotic patches in the mouth. Loss of teeth, nowadays it's not unlike old days. Most of us, even at 70s, 60, 70, 80, usually have their own set of teeth. And if they are gone, you should really question them, especially if they are coming with symptoms associated with any sinus disease. It could be an underlying malignancy. Palate, high arch palate, as you know, Marfan's. So you should look for that. If you're planning to take a graft from the mouth, of course, the mucosa of the mouth also should be inspected. Now, sinus examination. See, all these sinuses surround the eye. And one doesn't realize that a lot of the sinuses diseases can actually present to you as the headaches. They can come with swelling of the eye, even proptosis is possible if tumor goes. Even plain sinusitis you can have. Very severe sinusitis patient can have a mild proptosis because the inflammation goes into the orbit. So you should pick up those signs. I'm just going to stop my share so that you can see me what I do. Looking for tenderness of the sinus, one really needs to, you can just tap like this on the frontal sinuses, or you can tap like this on the maxillary sinus area to look for tenderness. Ask them, is it painful? Especially compare one to the other and see. For ethmoid sinus, you can actually press here medially. Even the frontal sinus you can pick up. Just press here medially on either side and ask them if it is tender. If it is tender, then especially if it's only on one side, then it's more likely that the patient has a sinusitis, inflamed sinus. You can even ask the patient to actually bend down like this, below the level of the knees, and if one side is painful, then again the patient could be having the patient could be having a sinus problem. I'm going to now switch off the light. So sometimes you don't in the clinic you want to know whether the sinus is full. Is there a sinusitis? Is there a malignancy? A simple way to check if the sinus is okay, especially especially the lighter you are pigmented, the better. All you really need to do is take a torch like this and shine it into your mouth. Okay, like this. I'm just going to. I hope you can appreciate my sinus, the maxillary sinus being transilluminated. Okay. So I think that's a useful test to do, looking for transillumination in the sinus. Nasal page, the anterior part of the nose, the anterior part of the nose, you can always, I'm not going to stop the screen share, but if you can look at the smaller, this thing, just tip up, put your indirect, this thing, and just tilt the nose and look in the anterior part, you can make out. The posterior part, if it is completely filled with tumor or this thing, the air that comes out may be, it will be blocked. So in today's age, it's a little more dangerous probably to do that. But otherwise, what you can do is take a lid spatula and ask the patient to just, blow out with the mouth closed onto the spatula and look for the condensation. If one side there is no condensation, that side is blocked and there may be a tumor sitting in the back. Examination of the mouth we have gone through, so we will skip that. Now, examination of the hand, again, examination, if tremors classically for thyroid eye disease, if the hand is very coarse and, dry, very thick, then you may think of acromegaly. Long fingers, again, if you have very long fingers, especially in muffins, normally what you would find is your thumb and little finger just touches. But if if it is an extra segment is there, then these fingers are long and patient has probably Marfan syndrome. Marfan syndrome, another very easy way to make out whether the height is equal to the arm span. We don't need any tape. Just ask the patient to bend down like this, touch the floor and touch this thing. Mark it like, mark it as shown here. And then after that, you just compare. Okay. And that's a very simple way to make out if there is some offense. Now, if some patients come who complain of puffy of face, or let's say diabetic who comes, you may want to know whether his kidney functions are reasonably all right or not. You may want to check his leg to look for edema. Edema is normally checked for above the malleolus on the tibia, which is just under the skin in this area. Press for 15 seconds, release it. If there is a pitting, which is persisting, then you know that there is a fluid overload. And if there is no pitting, but you think there is some edema, then it's a mixed edema suggestive of hypothyroidism. An extra toe means could be Lawrence Moon middle. A foot drop usually you will see in leprosy and Hansen's disease. So that is some part of the general examination external we have covered. Then coming to neurology examination, the cranial nerves examination you should learn to do. The 2 optic nerve, oculomotor 3, 4, and 6 is part of general ophthalmology. We will not go through that here. Okay. The other cranial nerves we'll quickly go through. The last 4 cranial nerves not so important for ophthalmologists, but we'll just for completion I may just mention just one test which you can do. In this COVID era, examining the smell has become again important. So you can keep a small covered bottle of coffee and just ask the patient one nose at a time. Do you want me to? Okay, maybe I'll stop sharing screen so that you can see me better. So one side at a time, you just make the patient sniff and then find out, ask the patient, what do you think it is? And if they give you a correct answer, you know that this is. Then you have, so if 2, 3, 4 is, we're not going to discuss. Trigeminal 5, which is you're really looking at sensation. Okay, now for that in the past, people used to say, you have to make a cotton thread like this and then do it like this. And then, especially for corneal sensation, touch only one side at a time. That was the olden belief that, herpes used to go from one eye to the other. Now we know it's all sitting in the trigeminal, the ganglion. So really not very important now. But examination, I won't go to corneal sensation, but examination of the face or sensation elsewhere, what you can do is first touch the patient's, forehead and show them what it feels. This is how the sensation is. And then you ask them to close the eyes and then touch. And each time you touch, you should ask them to count. Okay. And so closing the eyes, you ask them to count each time you touch. And that gives you a good idea if they're really feeling it or not. If they're feeling it, then you may even want to compare the same side on both sides. Ask, is this okay? I mean, is there any difference in the feeling? Is it less? Is there a paresthesia? Oh, both could be important. Okay, so as far as we are concerned, we really don't have to, messeter if you want. You can just ask the patient to clench and just feel on either side, if you want to do that. The sixth nerve, I'm not going to discuss. Seventh nerve, as far as you should understand that the upper part of the face has representation on both, part of the cortex. So, and whereas the lower half is only supplied by the opposite half. Okay, and so supranuclear lesions, only the upper, the upper part, because it's got bilateral, will be intact. Whereas the lower half on the affected side will be gone. Whereas lower motor neuron, the classical bells, the entire thing will go. It's easy to pick up. The upper motor neuron lesion, by just asking the patient to say "ee" like that, very a gross testing is not very useful. They may be able to move, but you have to make them tell some joke or make them smile. That smile is what evidently elicits these upper motor neuron facial nerve palsy better. And that subtlety comes out at that stage. Then you have eighth nerve. To me, all you have to do is, you don't need any tuning for that. You just have to rub the fingers in front of the ear in both eyes. One, ask them, can you hear this? Can you hear this? And all of you, while listening, you can, try it out. And then after both sides, if they can hear you, then you can simultaneously rub your fingers in front of the ear, both sides, and see if there's a difference between the two. So that's the eighth nerve. These are the most important nerves for us. As ophthalmologists, very rarely we would need to check out the ones lower, but sometimes, you have a patient who has been called by, especially when you want to rule out mucor and things like that, which spread along the base of the skull, then you may want to check out. The ninth and the 10th nerve, the hypoglossal, the glossopharyngeal and the vagus, you check it together. You ask the patient to open the mouth and say "ah." When they say "ah," the upper palate, you check. If it's moving to one side, then the opposite side is paralyzed. That's applied by the vagus, the muscles for deglutination. Okay, the swallowing muscles. The uvula also will be shifted to the opposite side. Okay, generally not done. You take a long swab stick and then just touch the posterior pharynx and see the gag, but really not necessary. The accessory nerve, you can either do this or ask the patient to move on either side and check, is there any difference in the power. And the tongue will move to the opposite side. So if I have a left side problem, the tongue will move to the the tongue will move towards the lesion. So if I have if my left side is gone, the tongue will move towards that side. So that's how you make out the hypoglossal nerve. I'm going back to sharing the screen. Okay, now patients who you may suspect raised intracranial pressure, or patients who may have, suspecting vitamin B alcoholic optic neuropathy or something like that, the posterior column may be gone. And these patients, these patients with raised intracranial tension and like that may not be able to do tandem walking. Tandem walking is all, walking in a straight line with one leg in front of the other, just one, you ask them to walk, and the ones with posterior column problems or raised intracranial may not be able to do that. So you'll have to, of course, hold your hand on either side of the patient so that in case they fall, you have to hold them. The reflexes, I think it's a good idea for you to learn to do the reflexes, especially the knee reflex in patients who you suspect have got AD's pupil or something like that. You may want to check out the reflex to see if that is depressed. And all you really need to do is ask the patient to sit cross-legged and then just tap. Even with your hand like this, you don't really have to have a hammer. Just, with this, just do this on the, just below the patella, and you should be able to elicit. Sensation, we have already mentioned in the general sensation under fifth nerve examination with using cotton. You can use the same principle. Joint sensation, I just want to show you how to hold when you are checking whether the joint is flexed or extended. you should not give the patient any other clue. If you hold the patient's, here and on the underside, the pressure on as you open and close will be different. The patient may be able to say whether it's extending or not. So you hold on either side of the finger like this and then flex or extend for joint sensation, especially the posterior column diseases again. Cerebellar signs, when patients you have nystagmus, you just want to quickly see, okay, is there any cerebellar issues? And I find just one test useful, the hand to nose, finger to nose testing, where I'm not going to stop screen share. If maybe you can look at the smaller window. You ask the patient to, your finger is there and you ask the patient to sort of touch from his nose and then to your finger, okay? And if towards the end or towards the nose there's a problem, then the cerebellar sign is positive. And don't worry too much about localization of cerebellar signs. They're notoriously bad for localization. Abdomen, even the surgeons don't know what they're palpating quite often. And so abdomen and genitalia, I would just not bother even to examine. Respiratory system and the cardiovascular system. When you check pulse, you have to be a little subtle about it. Gently hold the patient. Don't tell them what you're doing. Because emotions can change the pulse rate. BP checking. All I want to stress is use an appropriate cuff. Like I was telling you, if you use a big cuff for a child, an adult cuff for a child, it's an invalid test. You are using the wrong instrument. So don't do that. Again, in cases like Takayasus, you may want to examine the blood pressure on the thighs or on the leg. You will have to use a bigger cuff to compare the BP on the upper limb and the lower limb. Okay. As far as hearts and respiratory sounds, as long as if it's anything more than a lub and a dub, don't bother where the, just say there is a murmur or there are some extra sounds. Even extra sounds, I find it very difficult to pick up. Then you need to refer the patient. Again, same with the respiratory sounds. If they're abnormal, then you will need to send the patient off. Yeah, this is one of the last examinations, carotid examination. If the patient has, let's say, transient, amaurosis, fugax, or a central retinal artery occlusion, or even orbital ischemic syndrome, ocular ischemic syndrome, it may be the carotid sets at fault. So it's important to use 3 fingers, stand behind the patient, go behind, and then just use the 3 fingers, come like this from behind, and one side at a time, just below the angle of the mandible, go and just gently press, and you will feel the carotid. And on one side at a time, don't press both together and cause an ischemia. Okay. If you want to compare very gently, you can compare, but don't press too hard. If you want to look for bruit, always use the bell of the step. Just again hold it there, and if there is a significant plaque, you may get a bruit. Thyroid, while you're examining the thyroid, neck, you can ask the patient to swallow, and if there is any obvious gland, that's the way to check out thyroid. Lymph nodes, the neck nodes are again checked from behind, standing and then palpating. But the submandibular and the submental nodes, if you are suspecting malignancy, you have to come in front and then palpate from here. Okay, just run your fingers across like this. It's important to understand that bad oral hygiene can also give you a submandibular node. So you have to, don't get fooled by that. So in conclusion, ophthalmologists are the only people who can have a peek into the human body with our clinical skills. Okay, 80% of human diseases may have an ophthalmic finding sometime during the course of their natural history. Systemic clues help in making ophthalmic diagnosis. And understanding the rest of the body is important not only to manage the condition, but also the human being the eye belongs to. Thank you. So if you have any questions, I can tell you. And while you're thinking up your questions, let me just also tell you something. Somebody asked me about super pinhole. I was looking up, what is a super pinhole, and it has it was discovered about 25. It was described 25 years ago, and I thought, oh, and then I saw one study which was done actually this century after 2000, and the test has a sensitivity of only 50%. You know what that means? You take a coin and toss, and the coin will also have a 50% of chance of telling you whether it's right or wrong. That's how bad this so-called super pinhole is. I wouldn't clutter my brain with that knowledge. I just hope, sometimes some examiners would have read it and just feel, they want to feel that they know more than the student, and then they want to ask. And I don't see any other role for this sort of, that super pinhole.
Thank you so much, sir.
Okay.
That was a wonderful class. It was like a person, a client coming with a history of kidnapping or a murder, and Holmes looking at his trouser for the type of soil.
Yeah.
And then clinching the diagnosis. So, does anybody in the audience have any questions?
Yeah, sir, can I ask a question?
Yeah,
sir?
please go ahead. Yes,
Harshini. So for looking for the lower phonacial conjunctiva to look for pallor, should we look at the conjunctiva or the vessels we should look at?
No, you look at the lower phonics. Okay.
So the vessel. So my doubt is
no. It's not the vessels. It's just the color. No. You just look at the color. It is just only the color. And it's also important for you to understand. You have to look at. I keep telling students, what is the most important thing you need to pick out abnormalities? What is the most important thing you should know to pick out pathology? What do you think, Harshi? Now, what's the most important thing you should know to pick out pathology? You should know normal. Okay. Unless you know normal, and how do you know normal? Just keep looking at many patients. Only then can you pick out what is abnormal. And also, in terms of pallor, unless the HP goes down below 5, you really can't make out too much pallor. Okay, but
okay, sir. Thank you, sir.
Sir, can I ask a question, sir?
Yes, please. Yes.
So when we go for like eye retrieval and all, if they don't have a death certificate, what and all should we look for, sir?
Death certificate, by that time you will not get, because the corporation takes much more to give you. What all do you have to look at?
Yes, sir.
Yeah, I think the consent is the most important thing. And if there is somebody who has declared a death, then that is, if it's done in the hospital, sometimes you get a death declaration from the hospital. If the patient is dead in the hospital. So that is probably enough. You don't need a death certificate. Then of course, you may have to have the discharge summary, but I presume all of people are now taking the bloods for the virus testing. But otherwise you just ask the history and what the patient died of, rule out that, this patient is not going to go for a medical legal autopsy, things like that. That is all I can really think of right now. Because it's not something I've been doing on a regular basis. I can't.
Thank you, sir. So one more doubt, sir.
Yeah.
Like now we get the spectacles in different shapes and sizes. What is the ideal shape we should suggest, sir? Like one might be very small and one is like very big. And what is the ideal size a spectacle should have, sir?
So let's first start with the young ones below 40. Okay, the ones who don't have presbyopia. They can decide on any size, because finally it's their nose who has to bear that, and it is their fashion sense and so I wouldn't give a size for it. But the ones who are after 40 and who needs a presbyopic glass, they should have a wider, the height of the glass should be enough so that it can fit in the addition. Otherwise, if it's too small, the transition has to be very quick, and that is not very convenient.
Okay. Thank you, sir.
So there is one question.
Yeah.
In a case of brain metastasis with vision loss,
Yeah.
any particular clinical test to justify like central vision loss or to prove that it is a central vision loss?
I mean, you have to do a field law. Oh, you mean, oh, okay. You're talking about the central vision. Okay. See, usually the central vision loss, goes by, there are two ways. One is, so you can have paraneoplastic causes also for vision loss. Yeah, that you can have optic neuropathy and things like that. In those cases, you'll have to do a visual evoked potential. But are you worried about whether the patient is going to malinger or what is the worry? So if it's an atom thing, they will, of course, they cannot, when they're walking and things like that, will make you understand or that this patient is not able to see, but they are still denying the the fact. Optic neuropathy for paraneoplastic, that's the way I would go. But patients, unlikely at that stage anybody is going to malinger, so that would not be a problem. I wouldn't worry too much.
So I think they want to know if the metastasis is in the occipital lobe or something, which is resulting in vision loss. If there is any particular test for that.
Oh, no. That is, in this day and age, nobody would do a clinical test for that. There would be multiple scans on that patient and we would know what is.
Okay. So another question is, any trick or important things to keep in mind when we are doing a 90D examination on slit lamp in an undilated patient?
The only trick I can tell you is you ask the patient, with the other eye to look at your ear. Okay, so ask the patient to look at your ear while you're examining. So two things it does. The patient looks even at a farther distance and won't accommodate trying to look into this thing and constrict the pupil further. And also that in that alignment, the disc and the macula, which is what is the area which we can see best with an undilated pupil, will come straight into your view. So that is the only thing I would.
Okay. Anybody else in the hot seat has any doubt or would like to ask sir anything? It's a good opportunity. Whatever doubts you have, you should clear right now. Okay.
Okay.
Maybe I should just ask something.
Sure. Yeah.
So, I'm just going by what is useful for the students. When we have to just mention the systemic history, it's for any ophthalmic examination, we usually just write no systemic abnormality. Yeah. But what are at least the essential things that we should ask any patient? The patient just says, no, I don't have this problem. But if we have to ask some direct questions, what are the basic things that we should ask them? Okay.
So, like history, I think the systemic examination also should be targeted examination. And there are two things. One is for our practical life and one is for the exam situation. For our practical life, let's say patient has glaucoma and thyroid is associated with glaucoma. So you ask a history, they don't, in the examination situation, you can make a show and say, I look for thyroid problems and things like that. Okay. Otherwise, it is not easy to figure that out unless the patient has obvious mixed edema or something like that. So I would really, like I said, subluxation. If I see a subluxation, I would be, if the patient denies injury, no, even if the patient says there's trauma, I would look for other features. Is there anything underlying that predisposed to that? So that is the other thing. Then, of course, when there's a cataract patient, you want to do the CVS and respiratory system quickly just to make sure this patient has no gross abnormalities. And you want to check a blood pressure and pulse. Otherwise, I would not, then of course, if you want to, you can look for any gross anemia and just look at the tongue probably. But beyond that, I wouldn't do anything. And I would think a targeted examination is more important, depending on what the patient has. And that you should know once, when you have a papilledema, like I said, you may want to check whether the patient has any tandem walking issues or cannot stand with both the eyes closed and the feet together, which again suggests that there is some imbalance, things like that.
So probably it's good to, after we finish the ophthalmic examination, to again just take some time out and decide what are the things we should look for in the systemic examination and go back to the systemic history once more.
In fact, I would do it that way. I would never start with the general examination. I will only do an ophthalmic examination first and then do the general examination.
Okay. We have one more question. So this is, I think, about posterior scleritis. Any clinical test apart from B-scan as an investigation? Any other clinical test that we can do for posterior scleritis?
In fact, whenever I make a diagnosis of posterior scleritis, it is almost 90% or more, it is by clinical examination. As I said, the most important thing is history. Okay, where how bad is the pain, when is the pain, nights, things like that, and has it happened before? So history is the most important thing. I mean, one of the very important things. Then another thing is, especially posterior scleritis, unless you look for it, you will miss it, and that is proptosis. Okay, you look for it, and invariably the proptosis is there. And how do you pick up the proptosis? Go behind the patient, tilt the head back and come forward to see which cornea meets you in the system. And that, to me, I find that a very sensitive way to pick out whether the patient has mild proptosis, and most of the posterior scleritis patient will have some proptosis.
Okay, sir.
I have a question, sir.
Yeah.
Sir, I wanted to ask, is there any proper or 100% method to block the rays coming from the computers or mobiles, like we use blue-cut glasses, or is there any other method that we can block or prevent from harming our eyes?
But who told you it's going to harm your eyes?
So the rays, eye strain and the pressure, the tiredness in the eye that we feel from the long working hours.
Yes,
From
tiredness of the eye is because of the long working hours, and more importantly, for some strange reason, we don't blink. Okay. When you look at the monitor, our blink rate drops very significantly. And I guess if you're watching movie, then you don't want to miss even that 1 second action, of that blink, so you just stare at the monitor. I think that's more important. The ray itself, I don't think is an issue at all.
Okay. So those blue-cut glasses, are these necessary if we are working long hours?
If you've got if you've got a share in that factory, you can use it and tell your patients also to use it.
Okay, thank you, sir.
Okay.
Okay, so we have one more question. In the pediatric age group, what are the things that we should look for in general examination, and particularly if the weight and height is important in every pediatric patient?
So the height is not important. So again, if for the exams, invariably they don't keep pediatrics. You're not supposed to keep pediatrics because you need consent and all those issues. So they don't keep children. But height is not really very important in our setup. We are not going to assess growth by that. Weight is important because we will probably have to give the medications, especially if there's any systemic medications like Diamox. We may want to give it according to the weight, but otherwise, no, not necessary to take the weight. The other examination, again, like I said, it should be targeted. It depends on what the patient has come for. There's no point doing a general examination for all the patients and you'll end up not doing any examination for anybody. Okay, so I would suggest, and don't feel guilty about not doing a general examination thinking, oh, you have to do the whole thing. No, that's not necessary. Just
okay. Up to what age is the birth history important?
So birth history, again, let's say a patient comes to you with one eye, blind, or it's looking very small, and then you ask the patient, look, what happened? And he says, I don't know. I was too small, and I don't know what, my parents never told me, or they were illiterate. Then you may want to take a birth history just to figure out what this patient had. And the myopia in the other eye may be because, an ROP was same in the other eye or something like that. So that way birth history may be important. Otherwise, I think we should sort of always say we will do it when it is necessary, and that will depend on the history, and it should be target. There is no one size fit all, and you don't have to feel guilty that you're not doing all the examination for it.
Okay, sir. And we have some more questions. If a patient comes to us with a history of road traffic accident as well as ocular trauma, what are the essential points in general examination that we should do in such a patient?
Okay. The first thing you really need to do is to check out whether it's an open globe or a closed globe. Is there any issues like that? Is there an open globe or a globe rupture which you cannot see straight away? That's the first thing you need to do. The other thing is check the vision. So if you're called there, you have to examine the vision, because sometimes just head injury, just a hit here, and you can have a traumatic optic neuropathy. It may be missed. So check the vision, check an RAPD. If the patient is comatose, then you have to be very careful even trying to do dorsal movement, because there could be a neck issue. So those are the things I would think of straight away, and then reevaluate once. If the neurosurgeons have decided to do a scan, you should also probably have a look at that.
Okay, sir. One question is, what is the role of oral Diamox in choroidal effusion?
Okay. So it has a paradoxical effect. I sort of think Diamox helps, especially post trabeculectomy. If you have a choroidal effusion, it's mainly for post trabeculectomy choroidal effusion. Diamox helps. It does two things. One is it prevents more aqueous production, and probably some little bit of maybe the bleb comes down. But for some unknown reason, the choroidal effusion becomes better.
Okay, sir. I think we have answered sir has already mentioned about the important points for 90D examination. And this question is, if we have an exam case, in that, do we mention in all cases the direct, indirect ophthalmoscopy as well as 90D?
No, I wouldn't. So again, that's the whole problem. Sometimes these examiners are so temperamental, and they have their own styles. But if I was an examiner, I wouldn't bother about the direct ophthalmoscope at all. I have not used a direct ophthalmoscope and it is ridiculous to expect an ophthalmologist to now use a direct ophthalmoscope. They should be all using only the indirect and the 90D. So, and if it's a skill station as a separate station, yes. But otherwise, I don't see, if the required assessment is, can this person evaluate a patient with an eye problem and come to a diagnosis? You don't need to do a direct ophthalmoscope, which does not give any additional information.
Sir, could you just tell us the importance of a patient who's on anticoagulants and has come to you for an ocular examination?
On anticoagulants and just ocular examination, I don't see any issues.
I mean, in general, anticoagulants' role or their importance in ophthalmology.
Well, to me, the only importance is if you're planning a surgery, that is one. And then in examination, or if they are coming with, let's say, subconjunctival hemorrhage. Some of these patients who are on this thing may come on with a subconjunctival hemorrhage. So that is one. Aspirin is also notorious for causing bleeds if you have age-related macular degeneration. So that is the in that context, I may ask, are they anticoagulants? The other way is probably to rule out any myocardial issues. I will ask them what medicines they have got, so that if there is any anticoagulants or aspirin or anything like that, it may give me a clue. Okay, this guy is, or if he's had a valve replacement. So mainly to understand the underlying systemic issues, that is the other time I would look at the anticoagulation related history, or trying to go down that pathway. In terms of, then the other option, like I said, is when I'm going to actually treat, especially cataract surgery and all, most of that now, most surgeries where even if there's bleeding, below INR below 2 is reasonably safe, they say. So and that is, and you can keep it at that level and continue. If you don't really always have to stop the long-term Coumadin and then start on short-acting this thing. It's not really necessary.
Okay. We have one more question. What are the ocular manifestations of typhoid?
Oh, well, I can't, I have no idea really what is ocular manifestation of typhoid, if there is any at all. I can't think of anything straight away. No.
So
Yeah.
Can I ask it out, sir?
Sure. But let me just give you a resource in the meantime. If your libraries have access to the old Duke Elder, that's one, the eye in systemic diseases, they've got a whole volume. So especially things like typhoid, I'm sure you may, something may be there in that book. So though I cannot recollect anything straight away. So, but that is a good resource. Yeah, please ask.
Sir, like if any of the systemic examination or the general examination finding is irrelevant to our ophthalmic diagnosis, can we exclude that in our case presentation, sir?
See, if you have picked it up and if you're going to do an exam, you might as well write it there. And if, don't present it, but if they ask you, then say, I had written it, I just forgot to mention. That is one way to do that. So if you have already picked it up, write it there, but you don't have to present it if it's not relevant.
Okay, sir. Then one more doubt, sir. If like less than 40 years in a myope, if they are using some narrow-sized glasses, will that affect the accommodation? Because for the near work, they'll be seeing out of the glass. So will that affect the accommodation, sir? Or the ocular hygiene?
So if you don't really need to see out of the glass. So in fact, you are saying that they will not be using accommodation when they're seeing near. Is that what you're trying to say?
Yes, sir. Like they'll be seeing out of the glasses if their glass size is too narrow. So will that affect the accommodation in a myope?
So you're saying they're seeing below the rim. Is that what you're trying to?
Yes, sir.
Yeah, they don't have to accommodate to see near. Yes, absolutely. If it is so thin. But usually what happens is people bend their head down a little bit so that they see through the glass. But if they're purposely doing that to, have a rim to avoid if they're closer to 40 and wanting to avoid a presbyopic correction, they can do that. And by the way, there is one more, let me ask you a question. Will you, let's say a 6-year-old child or a 7-year-old child comes to you with, just come for a systemic examination. Mother was just anxious, no complaints. And then you see a -2 or a let's say a -2 refraction error. Will you give the glasses?
No, sir.
No, you can give the glasses, but you don't have to insist that it has. Now there is more and more evidence suggesting that, wearing glasses itself worsens the myopia. Okay, so children who are growing, that's why now the atropine has come up in a big way. You use very low doses of atropine, 0.01%, to avoid this. And it may have some other ways of acting also. But, so nowadays, it's better not to insist wearing myopic glasses. Patients are not symptomatic. And if they're doing well in class, no issues, they can be without glasses most of the time. Or minimize the use of glasses when they come home, at least,
Okay, sir. So basically in myope, if you are out of the glass also, it's not going to affect their accommodation, sir?
No, it won't affect. You don't have to use the accommodation. That's all. You have your near point closer to you. You can see without the glasses. And if they are happy doing that, why would you worry?
Okay, sir. Thank you, sir.
So I have two more questions.
Yeah.
One is that the retinal vessels are the only vessels in the body which we can see directly.
Yes.
So, what are the systemic diseases that we can identify just looking at the retinal vessels?
So, straight away, first thing, of course, is diabetes, then hypertension uncontrolled, then all these sickle cell diseases, then vasculitis. There are, especially neurology and all that, there are a lot of patients with vasculitis. And then they send it to us to see if there is vasculitis in the retina. So that's the other, you can make out vasculitis. The diseases like Takayasu syndrome, you can make out. Atherosclerosis also, you will see the vessels which are appearing different. Then let's say carotid artery, if there is an embolus which is thrown out, and you may see a small embolus sitting in the periphery. So these are the blood vessel related this thing. Then not so blood vessel related would be, like I said, leukemia, very bad anemia, can also present with hemorrhages in the eye. Then, pregnancy-induced hypertension, you can sort of figure out. So these are some of the things I can think of straight away, which, you can make out diagnosis from the looking at the vessels.
And sometimes when we are treating ophthalmic conditions, whether with topical or with systemic drugs, some of these medications also have some systemic effect.
Yes, absolutely.
So
But
we need to keep those things also in mind when prescribing, when I ask the patients, particularly if they have something before.
absolutely, yes, absolutely. Those are the things you should take history after your examination. You may have to go back and ask, do you have asthma and things like that. If you're still not convinced, you may even want to put a stent and check out whether the chest is clear. Yeah.
Okay, sir. Thank you so much. I
you
think
so
one thing that just comes to my mind is a quote in The Adventures of the Dancing Men, where somebody asked that, "How did you ever know?" Well, because I looked for it. So,
Absolutely. That sums the whole thing up. Yeah. And if you don't know, you will not even look for it. And
so thank you so much, Professor Thomas, for this wonderful lecture. And we'll have more from you over the next few weeks or maybe months.
okay. Welcome.
We'll
okay then.
cover almost all the chapters of your new book, which is very nice.
Yeah. Okay then. Thank you.
Thank you.
Okay
So
then.
for the audience, we have OSCE coming up for the next 2 weeks. In fact, from July 15 to 31st, we have 6 sessions of OSCE, each of which is 2 hours, covering the entire ophthalmology. And if you want to be on the hot seats, 10 of you, then I have circulated a Google sheet. You can fill it up. And whoever fills it first can be given one opportunity in the 6 sessions. So it's mainly for final year students, but anybody is most welcome. Thank you so much. Good night.
Good
Thank you,
night.
sir.
Good night.
Thank you, sir.